All right, our lecture today is on movement disorders again, but this time with a focus on the hyperkinetic movement disorders. And so, in contrast to hypokinetic, and everything in the hypokinetic movement disorder looks like Parkinson's disease, right? You've got Parkinson's disease and Parkinsonism. But in hyperkinetic movement disorders, it's the movements are excessive, involuntary. The patients aren't slowing down and having a poverty of movement. So by far the most common movement disorder of all is essential tremor. And patients that have essential tremor often come in and ask to see a neurologist because they're concerned they have Parkinson's disease. It also presents with an asymmetrical tremor, but unlike Parkinson's disease, this is mainly a tremor when patients are using their hands to do something. So eating, trying to eat soup or, get corn on a fork and get it to your mouth successfully, holding a full cup of coffee or walking around with it. Handwriting becomes very shaky, shaving, putting on makeup, using a screwdriver, anything like that tends to bring out the essential tremor. And so this is mainly in the hands, but you can see 34% of patients have a significant head tremor. Interestingly, Parkinson's disease, it's frequently a chin tremor. That's very common in Parkinson's, but essential tremor, the whole head will shake. All right. Frequently the voice will shake as well. I actually just recorded this lecture. I'm now doing it the second time because I went to a YouTube clip of Katharine Hepburn to show a voice tremor, and somehow the audio went out. But anyway, the shaky voice. If you just want to YouTube Katharine Hepburn interview later in life, you can get a good example of what that is like. So essential tremor is autosomal dominant, so ask about a family history, and that will be helpful. So another very helpful thing historically is if the patient drinks alcohol, and ideally you like them to bring this up without you putting the idea in their mind, but is there any effect with alcohol? And most patients that have essential tremor, if they drink a glass of wine or a beer once in a while, will notice that their tremor improves. So that's a very helpful feature historically. I had a patient years ago who had a significant voice tremor, and she was a public speaker, and she took a shot or sometimes 2 shots of vodka prior to a lecture, and it just calmed her voice down and her head tremor down, and she was able to give the lecture successfully. So obviously as physicians we don't recommend that, and there are studies showing that there isn't a higher risk of alcoholism in patients with essential tremor. So it's mainly just helpful historically. Many patients with essential tremor will never see a physician. They have a mild course, they do well, and but if it's really interfering with their life, then they'll seek medical attention. So there are 2 medications, really only 2 medications that work well for essential tremor. Primidone, which is an older seizure medication. We'll talk about it in passing in the anticonvulsant lecture, and we'll kind of go over the mechanism. It's broken down into phenobarbital, but primidone is very helpful. And propranolol, which is a beta blocker used to treat high blood pressure. And also when we come to our lecture on migraine headache, we'll see that propranolol also works well for prevention of migraine headaches. So these 2 medications are the mainstay treatment. Interestingly, most step 1, step 2 board review books list propranolol as the drug of choice, but every neurologist that I've ever worked with tends to start with primidone first. And I don't know that there's any difference really in efficacy between the 2. If we have a really severe case, we can do deep brain stimulation. Okay, so you put a probe in the brain, and you don't need to know the details of that, but it actually can be quite helpful. All right, our next category are dystonias, and there are different categories of dystonias. I'm only going to focus on the idiopathic dystonias. So remember what a dystonia is. It's a sustained muscle contraction. And so here are the 4 most common idiopathic dystonias. Blepharospasm is an involuntary contraction, dystonia, of the orbicularis oculi muscle. And so patients have these episodes where their eyes will shut tightly. And this can be triggered by things like sun, the wind, and patients can even be functionally blind from this for periods of time, which is obviously an issue for driving. Okay, so all of these dystonias are very, very treatable with botulinum toxin injections. Medications are really not very helpful. But this is a really rewarding thing to do, and it's not very difficult. You can inject the botulinum toxin into the orbicularis oculi, usually 2 above the eye, 2 below the eye, and it's almost miraculous for most patients. They're able now to open their eyes, and it often takes a little while to find exactly how many units of the toxin to inject, but it's very, very treatable. Patients are usually quite pleased with the outcome. But remember, botulinum toxin interferes with release of acetylcholine through disrupting the snare proteins, but that effect only lasts 3 months typically. So patients need to keep coming in for their injections. Cervical dystonia, the older term is torticollis, is a dystonia of the neck muscles. And so these patients have twisting, turning movements of the neck. The head might be pulled forward or back. Patients often will fight the tremor. And so, if the head is twisting to the right, they'll try to keep pulling it to the left. And that results in a head tremor. So that's called a dystonic tremor. Okay, so an interesting thing about the dystonias is that these conditions frequently have what's called a sensory trick, which is an unusual thing that the patient has discovered that helps lessen the intensity of their dystonia. So as a couple of examples, a patient I saw with blepharospasm really liked to read, but that would trigger her blepharospasm. But she found that if she would just read out loud, that the eyes would stay open. So that would be a sensory trick. Patients are often embarrassed to tell you that because they think, this sounds, like it's a psychiatric kind of a thing. But, spend some time, and oftentimes these patients will share something unusual like that. As far as cervical dystonia, many patients find that just lightly stroking the chin can help to keep the head straight forward. Or if they're sitting, maybe with their back on something, if they just rest the back of their head on a chair or the wall, that will reduce the dystonia. So, like blepharospasm, cervical dystonia responds very well to botulinum toxin injections. You really need to know what you're doing and look at how the head is turning so you know which muscles to inject to reduce the dystonia. Spasmodic dysphonia is a dystonia of the vocalis muscle, and this can either cause the vocal cords to pull apart or together. If they get pulled together, then patients have a tight, choky voice. If the vocal cords get pulled apart, then patients have a very breathy, airy voice. All right, and you can inject the botulinum toxin into the vocalis muscle. Usually this is done by an ear, nose, and throat physician in conjunction with a neurologist. And so with all of these, we use EMG. We actually put the probe into the muscle, and we want to see that we're in the right muscle. So even with the vocalis, we get that needle in the vocalis muscle, we have the patient talk, and you can see the motor unit potentials, just like we talked about with EMG. You know you're in the right muscle, and then you can inject the toxin. Writer's cramp is one of many what are called task-specific dystonias, which means it's really just one activity that brings on the dystonia. So these patients really only have problems with their hand when they try to write. And so the fingers will go into an unusual posture. Maybe the fingers will curl down or the fingers will straighten out. And so it's very difficult for these patients to write. Other examples of a task-specific dystonia is many musicians have had this. So I was at a conference years ago, and a famous pianist had curling in of 2 fingers in his left hand when he would try to do a run on the piano. And so that also, you can inject the muscles that curl those specific fingers in, and he was very happy with his botulinum toxin injections. I saw a tuba player years ago who kept having his index finger curl in when he would try to press down on the valve of his tuba. That would be another task-specific dystonia. All right, now Wilson's disease is an interesting condition. You want to think of this in younger individuals who have a movement disorder. And really this should almost always be checked in people under the age of 40 who are presenting with some sort of a movement disorder. And so this is a condition of abnormal copper deposition in one of three places: the liver, the basal ganglia, or the cornea. And so patients may first present with Wilson's because of some liver changes and they're seeing a GI doctor, or it may present with more of a neurologic psychiatric manifestation. So copper deposition in the basal ganglia leads to a movement disorder. The tremor is somewhat unique in Wilson's disease in that it's more of a proximal tremor. Most tremors are distal in the hands. So Parkinson's, essential tremor, these are both distal tremors. In Wilson's disease, if you have the patient hold their hands out, the tremor more involves the shoulder. And so this is sometimes called a wing beating tremor. So they'll have some rigidity on exam, they'll have different types of dystonias, so maybe the toes are curling in or the foot is turning in. Most patients with Wilson's have significant dysarthria. So that's kind of a helpful clue. A movement disorder, a very profound slurred speech. And the copper deposition in the brain often causes a psychiatric manifestation. So this may be anything from anxiety, depression, or sometimes even a psychosis. Okay? So the neurologic manifestations can vary, but it's some sort of a movement disorder, and again, often with a psychiatric presentation. Copper deposition in the cornea leads to Kaiser-Fleischer rings. All right, so what happens in Wilson's disease is that we have mutations of the ATP7B gene, and there are, I think, more than 500 different mutations that have been found. So this causes a dysfunction of the copper transporter, and that protein is the ATP7B protein. And so we can see here that here is copper, and it's ingested and it's taken up in the small intestine, and so we can see that that absorption into the blood is by an ATP7A, different protein here. All right, so that is normal, and what normally happens is liver here breaks down the copper, and it gets excreted here by the hepatocytes into the bile, and via a normal ATP7B protein here. So if we have a genetic abnormality, mutation of this gene, that will cause a dysfunction of this protein, and so these patients don't normally excrete copper, so copper accumulates. And interestingly, there's another copper transporter here in the blood-brain barrier. There it is again, ATP7B. And so dysfunction here may be involved in that copper getting into the brain. You can see there are a bunch of other conditions that result in abnormal copper deposition, but Wilson's is the only one that you need to know about. So here is a Kaiser-Fleischer ring. We can see that copper deposition here in the cornea. Okay, and so we always want to do a careful eye exam in these patients. I'm not confident enough. There are enough things that can mimic this, so I'm always going to have ophthalmology see these patients if I'm thinking of a Kaiser-Fleischer ring. And two tests that can be helpful or absolutely necessary, I should say, for diagnosis. One is you do a 24-hour urine collection to assess for copper, which is always going to be very elevated. And then we can do a serum ceruloplasmin level, which is going to be low. So high urine copper, low serum ceruloplasmin. Now, one other thing which I won't ask you, I just find it kind of interesting. These patients can have a unique finding on MRI scan. It's called the giant panda sign. So here is the midbrain, and you can see the much larger area here around the red nucleus, which kind of creates this appearance here of the giant panda. So I just mention it for interest's sake, it's only seen in about 14% of patients, so it's not, that common. There's a lot you can do for patients with Wilson's disease, but I don't think you would be expected to understand the treatment of Wilson's at this point. But would like you to recognize the clinical presentation and how you make the diagnosis. And for sure, Kaiser-Fleischer rings would be high yield. Now, Huntington's disease, or Huntington's chorea, is the third condition we've talked about so far in this course that is a trinucleotide repeat disorder. So this is CAG repeats on chromosome 4. It's autosomal dominant. And so remember the other two, myotonic dystrophy, Friedreich's ataxia. And so there's a triad for Huntington's disease. I mentioned the family history. It's autosomal dominant, so unless the patient is adopted, this diagnosis is usually not much of a mystery because multiple family members have been diagnosed with Huntington's disease. So, like all the trinucleotide repeats, we may have anticipation where the trinucleotide repeats accumulate through successive generations, and this is especially prominent in transmission from father to daughter. And in pathology, they will talk about spermatogenesis and the mechanism of this. So this can even present as a juvenile Huntington's disease, where we have a very young individual presenting with the syndrome. So the other two features are usually the initial presentation is some sort of a personality change, mood disorder, frequently irritability, patients get into fights easily, maybe depression. And so onset would be in 40s or 50s. And so that personality change can often brew for several years before patients begin to have the choreiform movements. So remember, chorea is a quick, jerky movement. And so when I see these patients, I want to just have them relax, sitting in a chair. I'll often have them close their eyes and maybe count out loud from 20 back to 0. And so the focusing on doing that, counting backwards, will often cause them to relax. And what you'll see is they just can't stop moving. Their legs will twitch, they'll cross their leg, they'll move their arm a little bit, jerk their head around a little bit. And so they have these continuous movements. Now, motor impersistence is a very helpful something you can do on examination, and this describes the inability these patients have at performing a sustained motor task. For example, trying to tie their shoes. They'll put their hands down and start to tie the laces, but then the hands will jerk away, and then they'll put their hands back down again. So we can check this on exam in several ways. One is just ask the patient to stick their tongue out, and they can't just hold it out. They keep putting it back in, and then they stick it out again. Or you can ask a patient to squeeze your fingers tightly and ask them, hold tight, don't let go. And they can't just hold it tight. They have to let go, and then they squeeze again, and then they let go again. So that's called the milkmaid's grip, but it's really an example of motor impersistence. All right, in the later stages of Huntington's disease, the choreiform movements are replaced more by dystonic, sustained muscle contractions. And these patients look a little bit more like they have Parkinson's disease towards the end stage, less of the quick, jerky movements. Frequently, these individuals, they are aware of family members that have had this and what they've gone through, and so suicide attempts are quite high, up to 30%, and suicide rates are 5 to 8%. So we need to be aware of that and address depression in patients with Huntington's disease. So just to give you a big picture, look how common essential tremor is in comparison to Parkinson's, even twice as common as Alzheimer's, and you can see that Huntington's disease, by contrast, much less common. So Huntington's occurs in clusters throughout the world. I think in Venezuela probably has the highest density of patients with Huntington's in one area in Venezuela. Much less common in North America, and like it's almost unheard of in the Scandinavian countries. If we do a brain scan in Huntington's disease, notice that the whole brain is affected. We have atrophy everywhere. So look at the large sylvian fissures, and all the sulci here are large. So this reflects atrophy, hydrocephalus ex vacuo. All right, but notice here in the normal brain, we went over these labeled pictures last year. Here's a nice healthy caudate nucleus bulging into the lateral ventricle. And here we have no caudate nucleus. All right, so generalized atrophy. Look at the big lateral ventricles here from atrophy, but no caudate nucleus. So this is what we'd look for on a CT or an MRI scan for Huntington's disease. Now, just one medication I'd like you to know about for treatment of Huntington's disease, and that is tetrabenazine. So any medication that blocks dopamine can help with the choreiform movements. But tetrabenazine can be quite helpful, and it has a unique, well-known mechanism. So if we look at dopamine here being packaged into dopamine vesicles, this happens by means of a vesicular monoamine transporter here in blue. Okay, so what happens is tetrabenazine, here the green arrows, it actually blocks those vesicular monoamine transporters, so the dopamine can't get into the vesicles as well, so less dopamine is released. And again, if you have a hyperkinetic movement disorder, if you have less dopamine, then that tends to suppress the abnormal involuntary movements. Unfortunately, tetrabenazine is associated with depression, and so we really can't use it if we have a patient with Huntington's who's depressed or maybe thinking about suicide. But there are some newer medications out. I won't go into those, but we do have some other options in that case. All right, very quickly, hemiballismus we talked about last year. Remember that this is a subthalamic stroke, and so you destroy a large portion of the subthalamic nucleus here, so less glutamate goes out to the output nuclei. So therefore the internal segment of the globus pallidus is going to put out less GABA, so there's less inhibition of the ventral anterior nucleus of the thalamus, and therefore more glutamate going back to the motor cortex. And so again, that is a hyperkinetic movement disorder. So in hemiballismus, if a patient has a left subthalamic stroke, their wild flinging movements will be on the opposite, the right side of the body. Tourette syndrome is another hyperkinetic disorder that almost always starts in young individuals, usually before 11, most typically between ages of 5 and 7. And so these patients have multiple motor tics. And so they're usually stereotypic for the individual, meaning that different patients with Tourette's have different types of tics. So it may be a kicking movement with a leg, the arm flailing out, it may be jerking neck movements or facial movements. And what's often really helpful, though, to suggest, yeah, this is Tourette's, is that they also almost always have vocal tics. And this can take many different forms: throat clearing, lip smacking, sniffing, grunting noises, or other vocalizations. So it's motor and vocal tics. All right, so it really should almost always start before age 21. All right, if it's after that, then it's something else, almost certainly. And the next one's very important here. The tics need to have been present for more than 1 year. So childhood tic disorder, benign childhood tic disorder, is very, very common. And this goes away within about 6 months. So 2 of our kids had tics, but they went away. Right? So you don't diagnose Tourette's in children that have tics unless they've been present for a year and unless they have the other, clinical features. So coprolalia, which is shouting out obscenities, is talked about a lot, but is actually quite uncommon. I think I mentioned to the class last year there was a neurology article where they actually detailed the most common obscene words that were used in Tourette's syndrome. All right, so more common in men. In about half of cases, it'll just spontaneously resolve by the age of 18. Tourette's is highly associated with attention deficit hyperactive disorder and also with obsessive compulsive disorder. And this can be quite profound. So patients are, checking the door 10 times before they go to bed to make sure it's locked. I had a patient who every time he would walk across the line in the street, he had to back up, bend down, and touch it. It was quite disabling. So frequent hand washing. These would all be examples of OCD. Tourette's is transmitted by what we call a bilineal transmission, which means you need genetic abnormalities in both parents. Treatment would include dopamine blockers. I'm not going to go into the various dopamine blockers that are used for Tourette syndrome. If someone has a very focal tic that's quite prominent, maybe painful, troublesome, you can do botulinum toxin injections into selected muscle groups, which can help some individuals. All right, and we'll finish up here with neuroleptic malignant syndrome and serotonin syndrome. So you need to compare and contrast between these two. They have a similar presentation, but they're due to a different group of medications. So neuroleptic malignant syndrome is due to dopamine blocking medications. And so these are either the neuroleptics or the antipsychotics, haloperidol, lots of others that you will learn in psychiatry. And oftentimes what happens is a patient is maybe on something like haloperidol, but then maybe they have nausea and GI symptoms, and they get put on an antiemetic. So maybe they get put on metoclopramide or prochlorperazine. And so now we're just blocking way too much dopamine. That would be a high risk for developing neuroleptic malignant syndrome. So the symptoms are brought out by dysfunction in the basal ganglia and hypothalamus. And so patients present usually with confusion. It's an agitated confusion. And frequently from dysfunction in the hypothalamus, they have fever and oftentimes blood pressure instability, heart rate changes, because the hypothalamus is the head ganglion for the autonomic nervous system. And so oftentimes these patients come into the emergency room and they're felt to have an infection, right? And that would be actually most common if you have a confused patient with a fever. Well, it's a pneumonia or a urinary tract infection, something like that. But these patients also have a movement disorder. So they have rigid muscles, they have a tremor, okay? And so in that context, that triad, look very carefully at the patient's medications. You don't want to miss neuroleptic malignant syndrome. You want to diagnose this early. So it's a clinical diagnosis. If you were to do a creatinine kinase that we talked about with muscle diseases, it's going to be elevated because the muscle rigidity is very intense. There's a lot of overactive muscles, all right, but that's non-specific. So it's a clinical diagnosis, and so we'll generally admit the patient, give them fluids, support them, stop the dopamine blockers for a period of time, and frequently we'll give them one of 3 medications. So dantrolene is a medication that blocks calcium release from the sarcoplasmic reticulum. So this can quite potently relax muscles. And so that rigidity will kind of relax. And we can give bromocriptine, which is a dopamine agonist. Remember in the Parkinson's lecture I told you this is a dopamine agonist we don't use for Parkinson's. But interestingly, it's the dopamine agonist we usually use for neuroleptic malignant syndrome. And amantadine, that other Parkinson's medication, which I told you can help a little bit with Parkinson's. It helps with dyskinesias. This also can help patients with neuroleptic malignant syndrome. All right, now serotonin syndrome is due to usually multiple serotonergic medications. Now, especially this could be seen if the patient is also taking illicit drugs that promote release of serotonin, so cocaine, amphetamines, ecstasy. So your patient who's on fluoxetine or Prozac, who maybe also takes amphetamines, that would be someone at risk for getting serotonin syndrome. So you will learn about all of these medications in psychiatry, but you really need to know the ones here in this second bullet. They're just high yield for step 1. So the SSRIs, the selective serotonin reuptake inhibitors, citalopram, fluoxetine, sertraline, they're so commonly used, so it's just something you need to learn. And then we have the serotonin norepinephrine reuptake inhibitors. And again, both of these are commonly used, duloxetine and venlafaxine. And so usually patients with serotonin syndrome are on more than one of these medications for their anxiety, depression, obsessive compulsive disorder. They're commonly used medications. Now, if you're an emergency room doctor, it's important to know that two pain medications that involve opioid receptors, meperidine and tramadol, do decrease the reuptake of serotonin. So we need to be careful giving these medications for pain. These are medications you can give as a intramuscular injection or IV. And if your patient is also on an SSRI, you don't want to put the patient into serotonin syndrome. Now, the last two bullets I will not ask you about because they always show up on lists, but these are almost never associated with serotonin syndrome. So monoamine oxidase inhibitors are used in the treatment of Parkinson's. So rasagiline is the one that's mainly used now. And anytime I try to order rasagiline, I get big alerts and often phone calls from pharmacists if the patient is also on an SSRI or an SNRI. But in reality, this is almost never associated with serotonin syndrome. So just to be aware, it concerns people, but there isn't a lot of evidence that it's much associated. Likewise, serotonin agonists like sumatriptan, which we will talk about as a great abortive treatment for migraine headaches. It stimulates serotonin receptors, almost never associated with serotonin syndrome. So these last two categories are really low risk compared to especially bullet point number 2. All right, so notice the overlap here with neuroleptic malignant syndrome. These are confused, agitated patients. Okay, that's just like neuroleptic malignant. They have autonomic hyperactivity, so they're an agitated, confused patient that has a fever, blood pressure and pulse changes, just like neuroleptic malignant syndrome. And they also have a movement disorder. They're rigid, they have a tremor, just like neuroleptic malignant syndrome. All right, so what really helps you here to distinguish the two is that in serotonin syndrome we have hyperreflexia, Babinski sign, clonus, in other words, upper motor neuron findings. All right, so these findings on exam, which go away pretty quickly once you stop the offending medication, but this, along with just looking at the patient's medication list, is something that's unique for serotonin syndrome. All right, so stop the offending medications. Again, these are patients often admitted to the hospital until they improve. Oftentimes we'll use benzodiazepine medications to sort of relax the patient, kind of get them through the difficult period of time, but you don't need to use those for very long typically. And we can use a serotonin antagonist called cyproheptadine. Okay, so it blocks serotonin and it can help patients turn the corner a little faster. So again, how to distinguish serotonin syndrome from neuroleptic malignant syndrome? They have upper motor neuron findings on exam. And they do have a little bit faster onset of symptoms and also faster resolution of symptoms once you stop the offending medication, maybe put them on cyproheptadine. So it's a pretty short course. And then just looking at the medication list makes it pretty obvious. If they're on lots of serotonergic medications, then clearly this is not going to be neuroleptic malignant syndrome. Okay, we'll stop there and we'll have a chance to show lots of videos next week to illustrate all of these conditions.